So why would that be? Why are people telling us that physical activity is good for them and yet not doing enough physical activity? And so we thought maybe it's not what they're telling us explicitly. Maybe it's what they're believing.
Welcome back to the Modern Pain Podcast. You just heard from this week's guest, Brian Pulling, sharing the big questions that inspired the study we're diving into today. This research takes a closer look at why so many people with knee osteoarthritis avoid physical activity, even though we know it's one of the best ways to manage their pain and improve how they move and feel. This research looked at something called implicit threat associations. These are subconscious beliefs, the ones people aren't even aware they have, that can make them associate movement with danger. Researchers used a tool called the Implicit Association Test, or IAT, to dig into these hidden attitudes. They studied over 550 participants, including people with painful knee osteoarthritis, people with other lower limb pain, and pain-free controls. What they found was really interesting. People with knee osteoarthritis had much stronger subconscious associations between movement and danger compared to the other groups. And here's the twist. These hidden beliefs didn't always line up with what people said when asked about their pain, activity, or fears in self-reported questionnaires. This mismatch highlights a big gap between what patients constantly believe and what might be driving their behaviors under the surface. I sat down this week with the lead author, Brian, and discussed his unique story that had him drop out of his physical therapy training here in the States and move his life across the world to study pain.
So on my lunch break one day, someone put a copy of Lorimer Moseley and David Butler's Explain Pain in my hands. And I read it voraciously. I just flipped through it as quick as I could to try to inhale all of this new information that I'd never seen. I'd never heard of pain science education, or really pain science in the first place. And a lot of what I was reading sometimes directly contradicted what I'd learned in school.
Society is full of information that feeds conceptualizations that physical activity is not safe for knee osteoarthritis.
We've got these sort of complex conceptualizations all throughout the community, even among people without knee pain, that doing too much activity or doing the wrong kind of activity is harmful for knee OA.
Another big problem out there is that clinicians managing knee pain with patients often hold these very implicit and explicit associations.
I do think that there probably are too many people practicing who also hold these beliefs that are not necessarily aligned with contemporary evidence for how we think knee OA works.
Brian and I spoke about ways we can engage patients in conversations around their beliefs to help them shift them in a more adaptive direction.
Based on your score to this test, it seems like implicitly, deep down, you have this knee-jerk reaction to associating physical activity with danger. Why do you think that might be? Let's talk about that. And let's see if we can investigate that further. And that might help someone who's not going to have a eureka moment. They're not going to have a light bulb moment where everything just clicks all at once.
We'll unpack what all this means for us clinicians, why addressing these hidden attitudes might be key in helping our patients move more, and how this research could change the way we approach chronic pain in practice. Stick around. This is an episode you don't want to miss. Now, on to the episode.
This is the Modern Pain Podcast with Mark Cardula.
Brian, first off, thank you for joining us in the podcast. And before we went on, Brian told an interesting story. I had no idea. I looked at Brian's LinkedIn and I'm like, is Brian a physio or is Brian not a physio? I'm like, but I know he's a high-level researcher. Obviously, he's pushing out some great research that we talked about. But I'd love if you could share with the audience, Brian, a little bit of your journey of how you ended up in Adelaide, Australia.
Yeah, sure thing. Thanks for having me, Mark. It's great to be here. It's an interesting story. Like you said, I originally planned to be a physio. I grew up in New York. So I went to a small liberal arts college in New York, and I was studying aging and orthopedics, and I was really interested in chronic pain. I really wanted to understand how to help people with persistent low back pain, for example, or chronic regional pain syndrome, fibromyalgia, things like that. So I went and I finished my undergrad. I was doing my first clinical rotation in an orthopedic outpatient rehab clinic, seeing a lot of people with knee pain and back pain. And around 70% of our patients did really well. They responded really well to treatment. We did a lot of manual therapy, a lot of pretty straightforward orthopedic rehab. But there was still that proportion of people that just weren't really responsive to treatment. And I found that really challenging because I was still in school and I didn't really have that expertise to know what to do for these people. So on my lunch break one day, someone put a copy of Lorimer Moseley and David Butler's Explain Pain in my hands. And I read it voraciously. I just flipped through it as quick as I could to try to inhale all of this new information that I'd never seen. I'd never heard of pain science education, or really pain science in the first place. And a lot of what I was reading sometimes directly contradicted what I'd learned in school, which I found really challenging. So I started to reach out and try to learn more, reading research papers and watching, video lectures on YouTube. And I was realizing that there's this whole world out there about pain science that extended well beyond what we were learning about basic orthopedics. And I found that really exciting. The path winds and one thing leads to another. And I didn't end up finishing my PT degree. I decided what I really want to do is research this. I want to study how pain works and how it affects people and how people experience pain throughout their lives. So I was really interested in aging and aging over the lifespan and how people adapt to changes in their environment. How do I actually do that? That was the real question. So I started to reach out to people, and I thought, you know what, Lorimer Moseley is the big name in this field. He's probably getting a lot of emails on a daily basis. He might not be so keen to reply to an email from some guy in New York. But Tasha Stanton out in Adelaide is looking for students, and she works with Lorimer, and she's done some really cool research. And I've seen her online talking about what she's done in pain and perception research, which I found really interesting. And so she might be able to respond to an email and just answer some questions, point me in the direction of some cool research papers, that sort of thing. So I remember sending her an email and asking for some ideas. And she got back to me and said, oh, if you really want to study this, if you really want to learn about this, you should just come here and do a master's degree. And I was right at that point in my life where I was naive enough and adventurous enough to hop on a plane and move my whole life to the other side of the world. And that was about 6 or 7 years ago. And I've been here ever since. So I did my master's degree here in Adelaide. And then I went back to the States briefly to do some work at Boston Children's Hospital and Harvard Medical School, which was really interesting. And then got back on the plane right before COVID took off and started my PhD. So I'm now Dr. Brian Pulling. I finished my PhD last year, and I'm working as an epidemiologist at the South Australian Health and Medical Research Institute, studying aging and using big data to understand how people experience the aged care sector.
Just an interesting story of how it seems like I talk to more and more people and they have that like existential crisis or that aha moment, especially when it comes to pain, when you get some of this literature. Louis Gifford's stuff was a big one for me. Definitely Lorimer and David's book, Explain Pain, was a big kind of change moment for a lot of clinicians out there. So it's always fascinating. I don't know how many of them have moved across the world like you did for it, but I mean, kudos to you, and kudos to you for crossing the finish line on a PhD. I know that's an immense amount of work and a massive undertaking. So congrats for that. I'd love to talk, because a lot of what we're going to talk today probably is a result of a lot of the hard work you put in your PhD. The study we're lead author on spoke to implicit threat assumptions and this development of like an implicit association testing for osteoarthritis, and to check the differences between if there was some predictability of this with, and I'll let you get into the details of it, but I'd love if you could lay the groundwork of what inspired this look at implicit associations and implicit threat associations in this work.
Tasha Stanton, my mentor, has been doing a lot of work on knee osteoarthritis and trying to help people recover from knee osteoarthritis or get back to what they enjoy doing. And what we know, probably more than anything else, for people with painful knee osteoarthritis is the thing that really helps the most people is physical activity. Everybody stands to benefit from doing physical activity when they have knee pain. And that is a complicated belief because a lot of people have a strong belief that physical activity is damaging to the knee because of these narratives around wear and tear and bone on bone ideas about how knee and so we've got these sort of complex conceptualizations all throughout the community, even among people without knee pain, that doing too much activity or doing the wrong kind of activity is harmful for knee OA. And that's really complicated, and there's a lot to that. But the main thing is that in the clinic, particularly among physios, their goal is to get people moving, and people with knee OA get them moving through walking programs and strengthening programs and things like that. And there is some fear, avoidance, and concern among patients and people with painful knee OA to engage with physical activity. So the question then is, how do we provide the right information, the necessary information to help people feel confident and safe to move so that they can benefit from this evidence-based and guideline recommended treatment. And so we turn to things like pain science education, and we teach people about why it's okay to move, why it's good for them to move, and how it'll help their pain and their knee recovery in the long term. And that works for some people, and that's really great to know, but it doesn't work for everybody. And I will say that not everybody has these explicit beliefs that physical activity is bad for their knee or harmful for their knee, but it is fairly common. So we thought perhaps we were coming up against people who would tell us straight up, exercise is the best thing for me. Exercise is great for my knee. Use it or lose it. I have to move while I can, and it will help me either put off surgery or maybe even avoid surgery together, which is great to hear. And yet, even among those people, the majority of people with knee OA aren't meeting guideline recommendations for the amount of physical activity that they should be doing over the course of a week, for example. So why would that be? Why are people telling us that physical activity is good for them and yet not doing enough physical activity? And so we thought maybe it's not what they're telling us explicitly. Maybe it's what they're believing implicitly, non-consciously. And so then we turn to the implicit association literature, and we look at what research has been done in the past to look at what people believe deep down in their belly. And one way of doing that is through implicit association testing. And this has been done for many years. It's a relatively old field of study to evaluate associations that aren't explicitly reported, to evaluate what people believe but don't say. And so this comes out when people are being asked questions about really sensitive topics. So most of the research has nothing to do with health or physical activity or anything like that. It comes from areas of psychology that look at things like racism and ageism and political beliefs or stereotypes around gender and sex. And they're the topics that are really hot button issues that people might say what they think the researcher wants to hear. And we call that a response bias. Now, when you're in the clinic, and particularly when you're in a research-based clinic, when you're working with people who have volunteered for a research study that they hope will decrease their pain in the long run, there is a risk of response bias. And by response bias, I mean a non-conscious desire, I guess you could say, to tell the researcher what you think they want to hear. Now, it's not that they're lying. It's not that they're faking anything like that. It's when people go into the clinic and they want to get better and they want their clinician to be successful because that means that their treatment is working and that means that their pain will decrease. So it's intuitive. It makes sense. And it makes surveys very difficult because a survey lends itself to a response bias. You give someone a survey where they're ranking questions from strongly agree to strongly disagree or 0 to 10 scales, things like that. And they're going to want implicitly to give scores that improve over time throughout the course of the treatment or throughout the course of the research study. So we turn to the implicit association test. And they're pretty popular and common. You might have done one. I first took one in Psychology 101 at uni, mostly for fun because they're kind of interesting. And essentially, they're a categorization test. So if you imagine you've got your keyboard, you're sitting in front of the computer, and on one side of the screen is a word, and on the other side is an opposite word. So for our study, it was safe on one side and danger on the other. And you put your hands on the keyboard, and basically you're using opposite keys to assign an image or a word in the center of the screen to one of those two categories. So you look at a photo and you say, is that photo safe or is that photo dangerous? Or you might even go more basic than that and say, is that photo active, an activity, or rest? So no activity. And the goal is to assign these images or words as quickly as possible. And the idea is, if you're doing this really fast, and we're talking like milliseconds, blink of an eye, really focusing on knee-jerk reactions, if you'll pardon the pun, the idea is that you're bypassing conscious deliberation over what you think the right answer would be. So if you're looking at an image of a knee in a mid-squat and you want to give the right answer to your physio who's doing a physical activity study about the safety of physical activity, then you might be more inclined to say, oh, that image, if I think about it, that must be safe because the whole point of this study is that physical activity is safe. But we want to know deep down in your belly, do you really think it's safe? Or do you have an implicit bias or an implicit association between physical activity and danger? And so it's quite straightforward. That was the goal, to see if we can use this relatively forward and evaluated methodology in a new context. This has been done before for back pain and lifting by JP Caniro, one of my collaborators on this project. He developed an IAT, an implicit association test, to see if people thought bending, like doing deadlifts or lifting boxes with a round back or a straight back, was either dangerous or safe. That study found, yeah, definitely people think lifting with a rounded back is dangerous. Lifting with a straight back is safer. And there is conflicting research over whether or not that's actually the case. He's found evidence with Peter O'Sullivan that actually lifting with a round back is not particularly riskier than lifting with a straight back. So there's a whole thing about that. That's a whole other area of study. But at least in the context of knee pain, we were just interested in whether moving at all is safe or dangerous. That was our main question.
Yeah, it's as you spoke to that too, and as I was reading the study, it was interesting because my question is always like we use the WOMAC in clinic, and sometimes I just wonder, like, our patients, because you'll see times where people score like very high. Yeah, nothing, no problems, I'm doing great. And then you see when they're in the clinic and how they behave and do things, and it's just diametrically different, where I thought this was a pretty interesting design in these type of tests. I could see like some significant clinical utility as far as having tests that really bypass this response bias that you spoke to and really get into people's deep down, maybe implicit beliefs that don't let them get into that rationalizing, kind of conceptualizing way where they're trying to think of what does this clinician or researcher want me to say, or what would look best as me developing through this study or this plan of care. I'm wondering if you can speak to what you found with that testing and what you saw as compared to, because you had three groups. You had the lower extremity that were not maybe knee OA related lower extremity pain, a control group, and then an osteoarthritic knee group. But I'm wondering if you could speak to a little bit of the results of what y'all found with that.
Yeah, so whenever anybody is developing a study, particularly designing a new assessment tool that's never been used before, really what we hope for as a PhD student, what we hope for is just to meet the bare minimum sample size requirements. We were trying to recruit people to do this test in the middle of COVID. It was initially we had these grand plans. People were going to come in and do an intervention and try the test, and it was going to be beautiful design. We had a really hard time recruiting people to do this test. And we were very fortunate that people were so gracious with their time and willing to do this test because it's all online. It's very straightforward. You can administer this type of implicit association test in about 7 minutes. It's quite quick. And I really couldn't be happier with the results just because they're so easy to interpret. If you look at the charts and the figures in the paper, like you said, we had three primary groups. We had people with knee OA pain, people without pain, just from the community who were willing to do this test. And we did have an age-matched sample. And then we had people with lower extremity pain that was not knee pain. So that's mainly hip pain or foot and ankle pain. And what we found is that by far, dramatically, people with knee pain had the implicit association that physical activity is dangerous, that knee movement is dangerous. And so that, on the other hand, rest is safe. And that was a significant difference to people without pain, even in the age-matched sample, and people with non-knee lower extremity pain. Now, across the board, most of the people who did the test had some implicit association that physical activity is dangerous, but the differences in the magnitude of that association were pretty dramatic. And that's really important because if you think about the way this test is scored is on a scale from -2 to +2, where 0 means no association. I don't know why. There's a whole algorithm. That's what they've settled on. I don't ask those questions. The strongest associations were among people with knee pain, and they had in the direction of +1 was their association. Everybody else was much closer to 0, meaning no association, or if an association, fairly minor. And that's really compelling information because it means that something happens psychologically for people with knee pain that leads them to this implicit association. Now, I don't know where that is. I don't know what it is that makes that occur. It may be somewhere in the process of their treatment or their diagnosis, or just in the experience of having that pain that helps them develop this implicit association. We know that in the community, there is this idea that knee OA means wear and tear and bone on bone. That's what it means. People without pain have that experience and have that understanding, perhaps from media, perhaps from friends or relatives who have gone through the process of treatment for knee OA. I think pretty much we all know somebody who's had a knee replacement or a hip replacement. The magnitude of that difference is important. We can see absolutely people with painful knee osteoarthritis implicitly believe that physical activity is bad for them, is dangerous, which it brings up some really important questions about, now, what do we do about this? How do we treat this more effectively? Because these are the same people who will say openly, physical activity is great. Physical activity is the key ingredient to my recovery. So there's this, like you said, this dichotomy, this discrepancy in their explicit and implicit beliefs. And types of incompatible beliefs are fundamentally what make misconceptions. Now, that's one way to look at them, as misconceptions. I think there's another, perhaps more optimistic way to look at these. The core direction that all of this came from was educational psychology, if you can believe it. I do have a background in health science, and that was where I started this journey from. But really, everything that we're doing for people with pain is some level of health education. And now sometimes it's very structured. It's pain science education. It's a specific intervention to help people understand the science of pain and how it works and how it affects them. There are different ways to do that, but sometimes it's very straightforward. But generally, whenever we're working in the clinic with people with pain, and that might be the research clinic, or it might be an outpatient clinic or a hospital clinic, we're trying to teach them about their pain and their self-management of their conditions so that they can live the type of life that they want to. And so we're asking researchers and clinicians across the board to become educators. And that's a big ask. Education is difficult. It's not formulaic and standardized. It requires a deep and complex understanding of how people learn. And so I turned to learning theory. There's 100+ years of research on educational psychology and how people learn across their lives. And there's a whole lot of really interesting literature on and how people form really strong beliefs that are fundamentally untrue and cannot be true. And the main way that these misconceptions arise is when there is a bit of it that is true, that there's a fundamental core concept that fits well within with an individual's understanding of the world. And this other piece kind of globs onto it, and the individual doesn't notice. A person doesn't realize that they have these two incompatible beliefs that need to be reconciled in order for them to comprehensively understand the nature of the true concept. So we're talking about knee pain, we're talking about knee osteoarthritis, and that physical activity is safe. So they have this belief: physical activity is good for me. Physical activity helps me attain my independence and mobility and quality of life. But knee OA is caused by wear and tear, and the state of my knee is bone on bone. These both cannot be true. Until that person can reconcile those two incompatible beliefs, they have a synthetic conceptualization. I just think that sounds better than misconception, but it wasn't my idea. That comes from the literature.
Sure. And it makes me think with J.P. Canero's and Peter O'Sullivan's work, where because it's tough. Like I find, and I know David Butler's got deep into learning theory and how do we get into like educational and really looking at learning theory as we try to become educators in the clinic. But I sometimes wonder, and I'd be curious what your thoughts are on, because in cognitive functional therapy, obviously more geared towards low back pain, but would make sense to have translations to other joints in the body. They talk about behavioral experiments, right? Where you have this person with this belief and this behavior around like where they have to brace their core and keep their back in lordosis and don't dare bend it. Yet when you create clinical situations where they can challenge that belief, because I just sometimes wonder, and I'd be curious what your thoughts are around the fitting of like behavioral experiments in this population where all the pamphlets and infographics and things that we can put out, which are great. I'm not saying they're bad. They just, sometimes it's hard to translate to the real world where as a clinician, I think we have a unique opportunity to create clinical situations where that patient with NEOA can show themselves that activity is better, or you can unpack, because it's always fascinating to me because we'll have NEOA patients regularly where they'll say, yeah, how does it feel? Oh, when I first walk, it gets better if you keep walking. Or no, when I first get up and move, it's kind of stiff and it's achy. It's pretty bothersome. But the more I walk, the better I feel. But yet they still carry these beliefs. Well, I'm wearing my joints out. I shouldn't walk. And we'll get into some of where these societal and cultural narratives come from. But I'm curious what your thoughts are on, and maybe you all are looking at studying this type of thing. I can imagine that's maybe a question down the road of like, how do we shift these implicit beliefs in clinic where sometimes the education and speaking to it, and of course we still educate, and I tell people all the things about arthritis and statistics and the normalcy of it. My joke with patients it's like calling degenerative joint disease is like calling my head degenerative scalp disease. Usually gets a good laugh out of the patients, but I'm wondering how where you think like clinically shifting these implicit kind of associations may fall. Do you think behavioral experiments have a place here?
Yeah, absolutely. And cognitive functional therapy is a great example. Peter O'Sullivan's work has absolutely shown that there is a way that you can guide someone through this reconceptualization about the strength and stability or strength of their body, particularly for cases of low back pain where people have these really strong narratives, compelling narratives that they are frail, they are fragile. And I think that's something that needs a lot of attention. The fear avoidance model is a way of looking at how these narratives are self-reinforcing, where a person gives feedback to themselves about the state of their body, and that can feed these misconceptions and these narratives. So I think there is a degree of that, which is absolutely present for some people, not all people. We're making generalizations, but for people with painful NEOA, I will say it's really difficult to guide people through these reconceptualizations or this conceptual change. It happens slowly. It happens much more slowly than we'd like. And there's a lot of expectation that it should happen quickly in a certain way if we do things nicely. And sometimes we see these sort of eureka moments, light bulb moments in the academic or in the education literature. They call it a Gestalt type shift, where in a moment, in an instant, you can see it happen where a person relearns a complex topic. In this case, they relearn very quickly that physical activity is safe or that bending is okay. It's rare. And not because the physio is doing anything wrong, not because the patient is unable to take that on, but because that type of learning is fundamentally rare. People don't tend to learn something dramatically in an instant. Rather, this type of conceptual change is slowly. It does happen incrementally over time to the point where the individual might not even realize that it has happened. They just they slowly are living life differently because all of these different factors have piled up. So I'll give you the example. Really, what happens in order for this conceptual change to occur, three things must be true. First, the learning process must be important to the learner, or in this case, the patient. The person who has these incompatible beliefs needs to think that learning about them is going to be important. And a lot of people don't. A lot of people don't see the value in any type of clinical education. And I'm not limiting to an intervention. I'm not saying this is true specific to pain science education or therapeutic neuroscience education or even cognitive functional therapy. But generally speaking, throughout the world, learning has to be important if this individual is going to reconcile incompatible beliefs. The second thing is that the source of the new information, the source of the education, has to be compelling to the learner. So They have to have trust and sometimes faith in their physio or in the source materials that you're giving them to read in those brochures or books or websites or whatever it might be. That, again, is difficult and raises the importance of developing therapeutic alliance and rapport with patients. Fundamentally, that's why that's important, because they're not going to take on new information if they don't trust the person providing new information. This isn't shocking, but it is evidence-based. And the third thing is the hardest thing. In order for a person to reconcile incompatible beliefs, they have to care enough, they have to be bothered enough to notice that they exist in the first place. Stella Wozniacki, who's one of the pioneers in this area of educational psychology, it's termed conceptual framework theory. So Stella Wozniacki says that students should be bothered by conceptual inconsistencies. And that research comes from learning about maths, physics, things like that. In the context of health, patients should be bothered when information that they've learned and their experience don't match up. If a person isn't bothered by this idea that exercise is really good for me and my knee pain is caused by wear and tear, then they're not going to learn. They're not going to have that conceptual change. They're not going to have that shift that's going to allow them to really engage in physical activity or whatever therapy to the extent that it would be useful. Cognitive functional therapy is a great example that you raised because it gives people really compelling evidence pretty quickly that they are safe to move, because they're just put in a position where they have to move, or they have to question those preconceived notions or narratives about what is safe and what isn't. It's very difficult to replicate in randomized controlled trials because it's different for everybody. And those gestalt shifts are pretty rare in the community generally. The academic literature on that subject is nuanced. I know our lab has been looking at interventions that use pain science education and physical activity interventions, really fairly straightforward interventions, but that have been targeted to knee OA. So the content of that education isn't generally about pain neuroscience. It's specific to the experience of people with knee pain. And I think that's really where we're seeing a shift. We're seeing a shift away from just having people memorize facts. Memorizing facts about pain has a very limited benefit. It has some benefit, not enough to be satisfying. I mean, I think if we're talking about assessment tools, so you mentioned WOMAC, that's a great tool. There's some knowledge assessment tools. We've got the Revised Neurophysiology of Pain questionnaire. We've got recently, Ben Darlow developed the Osteoarthritis knowledge scale. These tend to be more about the facts of pain science. That's important. And we need those as researchers in particular. We need those because they give us important information about what a person knows about pain. But there's a lot more to these broader conceptual frameworks than just knowledge. Beliefs matter. Experiences and expectations matter a great deal. Frankly, I would argue that there aren't that many things in a person's life and experience that don't matter to the way that they experience pain. So we need more validated assessment tools that, maybe not more assessment tools, but we need assessment tools that are comprehensive, that evaluate the complexity of the experience of pain. The WOMAC does that as it relates to knee pain for pain, stiffness, and function, which is fairly comprehensive for an objective assessment for a physio. But there are a lot of other complexities once you start considering things like implicit associations. What about what a person believes that they can't express verbally? What about the things that a person is able to express verbally, but that might demonstrate contradictions? So things like exercise is good for me, but my knee pain is caused by wear and tear. One of the other projects that I've been working on, and I'm very glad to say will be published hopefully in the next few months, is called the Osteoarthritis Conceptualization Scale. And it's intended to be a comprehensive assessment of the conceptual framework held by people with painful knee osteoarthritis. So it asks questions about how people think about the importance of learning in their recovery, which is important if we're thinking about conceptual change treatments. It also asks about how a person understands the physiology of their condition and the knowledge underpinning how pain works and how osteoarthritis works. It asks questions about what they believe and expect for their future treatment. What do they think is the maximum benefit they could get if they go to physio? What do they think is the long-term prognosis for their condition? Do they know that they're going to need surgery regardless of what they do? And that's going to influence the way that they engage with their physio and the way they prioritize different treatments. So we've tried to use really innovative methods in psychometrics and statistics to model how people understand their condition comprehensively in a way that hasn't been done before. And we're really excited to see how that will be hopefully useful to physios who really don't have a whole lot of time to go through the long evaluations that we might be able to do in research, but aren't practical in a 10, 15, hopefully 30-minute session, but often not. But if I can give a physio an assessment, and the implicit assessment takes around 7 minutes, maybe I could give another assessment at the first appointment that takes sort of 10 minutes or less, but gives a really complex picture of a person's experience that might be useful to a physio who's trying to make treatment decisions, but doesn't really have any idea about where this patient is starting from comprehensively in the way that they think about NEOA. These are big issues that don't have quick answers, I'm afraid, but hopefully we can use assessment to improve or at least give physios an improved understanding of how people are experiencing their condition and where they're starting from.
No, I can definitely see the value in something like that, where it gives us a little bit more of a comprehensive picture of where somebody's at, maybe beyond just a traditional pain, stiffness, and function type measures. Like you said, WOMAC being good, but doesn't really get into some of the nuts and bolts of what we spoke to already. Thinking back to what you were initially speaking about of those three key concepts of things, I think learning process needs to be important to the patient. And this is where as a clinician, I think you need to get to the nuts and bolts of why it matters to that unique person in front of you. And that's where I think the unique therapeutic alliance you spoke to of being able to see how is this affecting your unique life? How is it affecting the things that matter to you? And if we think even from an acceptance and commitment therapy perspective, really keying in on somebody's values, what do they value? What really truly matters deep down inside that this is interfering with? And I think cognitive functional therapy too is kind of aims to push that out as far as bring that front and center when you talk through it, making sense of pain and different things. And I can definitely see how when you create clinical scenarios that hopefully where they see that what they've learned in their experience in the clinic they're having with you as a clinician isn't compatible. You even ask them, does this bother you? What do you make of that? I mean, it's often where I put patients in this like mental tug of war from time to time where you can see it's just this is everything I've been told and everything I've seen on YouTube and everything I've seen on Instagram University. And this is what I'm seeing in front of me, how my body's behaving front and center. So I think what you said makes complete sense with what we see clinically. And I'm definitely interested to hear, and we'll definitely push that study out when it comes to be published, sounds like here in the near future. I would love to know, obviously this measurement tool is going to be awesome. What other questions do you think are lingering out there that we need to answer or kind of see? And even before I do that, because this is one question I almost forgot about, have we done something like these implicit assessments? I know I've seen it in I don't remember if it was around NEOA, to be honest with you, but I know clinicians often hold implicit beliefs and things too that affect how they educate, affect how and I've worked in some pretty Mayo Clinic, great place, loved it, but I would see some of the primary care physicians doing the most unguideline based behaviors when they'd get back pain. Let's image it, let's inject it, let's do all these things that the guidelines say because they're humans that freak out about their condition too. But I'm wondering what your knowledge is on clinician beliefs. Have we had studies that have looked at that as far as when it comes to NEOA?
Yeah, that's a really great point. And you're right. Like we will talk about contemporary pain science or the most recent advances in orthopedics or rehab or pick a topic. And because you and I have interest in this, we're talking about studies that came out in the last few months. But the reality is that doesn't translate to the university for a decade or more. And that means that people who are practicing often don't have the most contemporary information available to them, because it's just they don't have the time to keep appraised, and hopefully we can continue to push that. But as it relates to implicit associations and attitudes around NEOA, yeah, I do think that there probably are too many people practicing who also hold these beliefs that are not necessarily aligned with contemporary evidence for how we think NEOA works. And so I tend to put a preface when I give talks on NEOA, or even when I'm teaching my students. I'll mention, I'm going to talk about some things that your other lecturers might disagree with, because they don't work in this very niche area very regularly. At conferences, it can get a little dicey because I'll talk about things that are not necessarily common knowledge yet. They're well evidence-based, but they're not necessarily common. One of the common ones is that NEOA is not very well. The idea that bone on bone is a reflection of NEOA is not very well evidence-based, despite being a common belief. When we actually look at knee, and this is challenging because radiographic evidence is the main way to diagnose NEOA. If you actually look at a knee that has OA, it's never bone on bone. It's never bone on bone. There's always some cartilage left. And let's complicate things even further. That cartilage can regenerate even in cases of pretty severe OA. There's some really interesting but complex and not finished research showing that the gut microbiome has some really important implications for regeneration of knee tissue. I don't know why, but it's cool. And also the big one is that more than anything, knee osteoarthritis is probably largely driven by a low-grade body-wide inflammation, not just knee inflammation. And I think that, to me, is the most optimistic and hopeful area of study in this field, because it means that there are body-wide targets to reduce that inflammation and hopefully improve the outcome for the condition. But again, this is very contemporary research. This is very recent. So we don't have translational evidence for all of this about how we actually make this happen in the clinic. In the context of belief, we know from some research particularly in back pain, J.P. Canero's work and some of Peter O'Sullivan's work, that physios have those similar implicit beliefs that bending with a rounded back is dangerous, bending with a straight back is comparatively safe. I suspect, but have not yet confirmed, that we will find something similar in people or in physios as it relates to knee pain. I suspect we will see a similar finding for knee pain, but that's yet to come. We'll see how we go. But regardless, I do always preface when I talk about learning in this context, I rarely use the term patient, because we're all learning about pain. We're all learning about treatment for this condition. And so the same rules apply to clinicians. So the idea that information must be important to the learner. The source of information must be compelling to the learner. Synthetic or misconceptions must be bothersome to the learner. All of this applies to physios as much or even more than it applies to patients. And so I'm very fortunate as a researcher to spend all of my time questioning myself. Wait, hang on. Does that make sense with what I learned yesterday? Hang on. Does this paper actually fit in the context of this other paper? Do these things that I said on that podcast yesterday make sense with what I've learned today? So that kind of thing, I think we all need to be a little bit reflective, because that's the only way that we truly learn. And we are susceptible, when we're interested in a topic, to a confirmation bias, a different kind of bias, where we might be more keen to believe the things that we think are most aligned with what we've been studying for a while now. And so if we're interested in pain science and we've been studying pain science for a while now, we're probably going to be more keen to agree and focus on the things that confirm that bias over time. And knowing that, I think, gives us an edge to try to highlight new information as it comes out and question those biases as they change over time.
There are just a lot of things that humans deal with that make it hard to shift beliefs, just like it's hard to shift beliefs with patients. Clinicians face the same thing. We're all humans that fall victim to biases and confirmation bias and all the things that make it hard to shift. Cognitive dissonance. I remember when people were threatening my comfort zone. I think we all try to group into a thought process that gives us comfort that, hey, I know what I'm doing and I'm helping people. Dang it. Don't you dare pull my security blanket out from under me. I want to get into some other things, but we did have an audience question that I want to throw at you. It was on Blue Sky, one of the new apps, social media apps. If you're on there, check. We'll put some links to that out. The question was, within a framework of fear avoidance, can we identify patients who have genuine mechanical reasons to be cautious / protective of movement and those who don't? Then possibly could we stratify to psychological versus physiological approaches based on this distinction? And do you think that's a possibility?
I think we all need to be aware of potential physiological harm and risk of injury, for example. And I think that's one of the key things for example, the fear avoidance model, cognitive functional therapy, which primarily utilizes that model, tries to acknowledge people and put people in emotionally or attitudinally triggering positions, physical positions or circumstances when it is known by the clinician that is a safe movement for them to be in. And so that requires clinical expertise. You just have to know that based on expected healing time, tissue healing times and disease progression and the state of the tissue, that it's perfectly acceptable for a person to do this simple activity like bending over or moderately squatting or something like that. But that the individual might not feel that way based on their experience. So one of the issues with cognitive functional therapy and the fear avoidance model is, what's the limit of fear? What's the acceptable limit of fear that individual can tolerate without going the other direction, without worsening and furthering that cycle of fear avoidance through what is essentially catastrophizing? And so I don't know that it's as straightforward as separating out the physical and the psychological, or in this case, the implicit and the explicit. And again, this is an example of something that comes up a lot with my students. We teach the biopsychosocial model. And a lot of people's first instinct when talking about that model is, okay, we're going to learn about the biological and we're going to pay attention to that in our sessions. We're going to evaluate the psychological and we're going to ask questions about that. And we're going to consider the social and the sociological as it relates to this person's welfare and experience. And those are not three separate domains. They were never intended to be three separate domains. They are wholly overlapping. They are not separate things that you can stratify just because they are separate components of the term. The reality is we are whole human beings. And while historically we've had a biomedical model of healthcare, a truly contemporary biopsychosocial approach to treatment cannot differentiate between those three because they are so entwined that they rely on each other to facilitate a person's experience. The same is true in the context of how we learn and understand our own health. My work is primarily focused on conceptual framework theory, where we pull together lots of different elements of experience. And so these are things like a person's knowledge, a person's beliefs, expectations, experiences, as they all relate to that person's pain or health more generally. You can't really separate those things out, which makes assessment a nightmare, because assessment wants one thing. That questionnaire better be about one thing, because statistically, we can't really validate a questionnaire that's about lots of different things unless we have an overarching or really underpinning theory for why those things would contribute to one thing. And in this case, the one thing is their overlapping conceptual framework. And that requires a whole different set of statistical modeling that hopefully you'll see in this paper soon. But historically, we've had a whole mess of assessment tools that look at one little piece of a person's experience. So they look at the knowledge or the catastrophizing beliefs or the phobia or the expectations for exercise or the expectations for treatment. And then we try to pile them up together to see how a person is experiencing their health, which works okay in research because we have time to do lots of different assessments, and is completely impractical in the clinic because they just take a certain amount of time. And so then you have to pick which are the most important to your method of treatment, to your clinical practice. And that is a really difficult decision. for clinicians. I think you're right to pick something like the WOMAC because it's very practical, very pragmatic for getting straight into how's this person experiencing their pain? What can they do or cannot do? But ideally, we would have a comprehensive assessment or maybe set of assessments that would allow us to quickly gain a better understanding of this person's experience so that we know what to target through education, through maybe it's counseling, through acceptance and commitment therapy or cognitive behavioral therapy. Maybe it's what do we expose them to in a cognitive functional therapy, or what scientific concepts do we prioritize in a pain science education or therapeutic neuroscience education framework. These are not really separate things, but they all rely on different information. And ideally, we could get a lot of that information quickly. So that's what we tried to do. I don't think, to circle all the way back to the question, I don't think we can easily stratify these concepts. And I'm talking about that from a statistical perspective. I do think that more information about, for example, the explicit and the implicit gives clinicians useful information when they're having conversations, when they're facilitating those difficult moments where the individual is just clearly stuck. So as you mentioned, when the person doesn't see the dissonance that they're experiencing, you might be able to say, okay, so exercise is good for you. Let's do this implicit association test. Now, based on your score, and happily the test gives you a score as soon as you've completed it, so that's pretty cool. Based on your score to this test, it seems like implicitly, deep down, you have this knee-jerk reaction to associating physical activity with danger. Why do you think that might be? Let's talk about that. And let's see if we can investigate that further. And that might help someone who's not going to have a eureka moment. They're not going to have a light bulb moment where everything just clicks all at once, but it might get them thinking in between this session and the next session, and again to the session after that.
Yeah, no, I agree. I think, again, it comes back to just creating clinical scenarios where the patient can start chiseling away. And I always find it just, can I create a clinical scenario each time where they challenge their own beliefs, right? Where we put that front and center, where they see their beliefs and they see their behavior, what happens in reality, and they can and then you have that discussion. What do you make of that? So this is what you've been telling me you think would happen if we've squatted or stepped up this step or whatever it may be. Yet this is what we're seeing. But I think you're right. It's that epiphany, eureka moments, although when they do occur, they're awesome, but they're a very rare thing to see in clinic. And again, I think sometimes too, when you want to gather data, being really good interviewer to get to the nuts and bolts of a patient, to ask questions, pull some of these questions from a PCS tool or a fear avoidance model. Obviously, if we have time and we can do some of these assessments, but sometimes, like you said, clinically, it's not a realistic thing. Brian, I could talk for hours more about this stuff, but I would love to know what kind of burning questions are out there that you are all looking to answer when it comes to taking this further as far as this around knee OA, or maybe you're looking into other areas of the body.
Yeah, the biggest question for me is, does implicit association relate to behavior? So we know that implicit association does not correlate well to explicit associations, which is actually a good thing because it means that the implicit association is telling us something that existing assessment tools like the PCS, like other explicit assessment tools don't tell us. So it's offering new information. That's really cool. But does it tell us something about what a person's behavior is going to be? So, for example, do people who score such that activity is dangerous do less activity? That's the key question for me. If people who are scoring that physical activity is dangerous, but then are going off and running 10Ks, the tool doesn't do a whole lot of good except that it's interesting and might facilitate other research or qualitative studies. But really, we need to get at that key question of how does it relate to physical activity? And then if it does relate to physical activity, can we change the implicit association such that physical activity changes? So that's where we're headed next.
It makes complete sense. And excited to see the results because in clinic, we try to do these experiments. Our N equals 1 of how do we shift this behavior? And I'll be interested to see what you all come up with because your group, amongst others, are some of the top out there that are doing some great work. And we all appreciate the time because I do know, especially trying to get that study rolling through COVID. I've spoke to a few researchers who had to navigate a pretty immensely challenging time when COVID came and made research an extra challenging endeavor for folks. So thanks again for your time and thanks for all the amazing work you're doing.
Thanks so much for having me, Mark.
For those of you listening, if you could subscribe wherever you're listening, or if you're on YouTube, if you subscribe, that would be great. Leave a review. And if somebody you know is a clinician struggling to manage OA or having some questions on what's going on with some of their patients with knee osteoarthritis, maybe share this episode with them. We'll leave it there this week. We will talk to you all next week.